Good morning, good afternoon, and good evening, everybody. Welcome to this, I think it's the 5th Coffee and Chai Expert Chat of the Healthy Mothers, Healthy Babies Consortium. My name is Marty van Lieren, and I'm the program lead of the consortium, which is hosted by the Micronutrient Forum. The consortium aims to drive collective action for improving maternal nutrition and specifically to accelerate the introduction of MMS in settings where diets are poor, where indicators of maternal undernutrition are high, where low birth weight is high, and where we believe that multiple micronutrient supplementation can then have a significant improvement in the maternal nutrition status and these birth outcomes. Before I introduce today's guest, I would like to quickly take you through the format of this chat. First, I think that our guest will give a short introduction on her topic, the evidence on adherence to micronutrient supplements. And then during her presentation or that time, all your mics will be muted. So the audience mics will be muted. Afterwards, you will be unmuted and everybody can ask questions by raising your hand or by writing your question in the chat box. And then I will bring the questions to our speaker, and we hope to have a good discussion. So don't be shy, make sure that you ask questions. That is the entire aim of this question and answer session. Now, when you're not speaking, please keep yourself muted and raise your hand, keep yourself muted so we avoid the background noise. When you speak, it would be great that you mention your name and your organization so that we know from what end you're coming. Maybe talk about the work you do related to MMS, but keep it brief because we only have 30 minutes and we would like to give everybody who is interested a chance to be part of this discussion. So thanks a lot. Any technical difficulties that you might experience, please type them in the chat. We have some support, somebody who can hopefully help you then. Now for today, I'm very pleased to welcome to this Coffee and Chai chat, Dr. Megan Bourassa. Megan is the Director of Nutrition Science at the New York Academy of Sciences, and she also leads the MMS Technical Advisory Group. Megan has a PhD in chemical biology, but it's been quite some time that she's now working on nutrition. Now, for you to explain the difference between what does the Technical Advisory Group do and what does the consortium do, the MMS Technical Advisory Group evaluates the scientific data related to MMS, provides guidance based on available evidence, and responds to scientific questions from the community. And then the consortium provides a platform in which you can disseminate the tech materials, and we can also connect the technical experts with the broader stakeholder community of the implementers, etc. So today, Megan will speak about the evidence on adherence to micronutrient supplementation during pregnancy. This is not only about the evidence on MMS, but it is bringing together also other supplementation like iron and folic acid. And what have we learned from that broader category of supplementation where the issues are? So Megan, I am delighted that you have made the time to be with us, and I'm very much looking forward to a stimulating discussion with the audience. So the floor is yours now.
Great. Thank you so much, Marty, for that lovely introduction and inviting me to speak on such an important topic. So today, as Marty mentioned, I'll be discussing the evidence on adherence to micronutrient supplementation, in particular during pregnancy. So all the information I'll be discussing is specific to pregnancy and supplementation. So as she mentioned, we are also the Secretariat for the Multiple Micronutrient Supplementation in Pregnancy Technical Advisory Group. And a lot of the work that I'll be discussing today was also done with the Technical Advisory Group and others. And my colleague, Philomena Gomez, who's on here, led a systematic review on interventions to improve adherence to supplementation during pregnancy. And so I'll be providing that in some of the extra literature at the very end of my presentation. And that'll also go in the chat at the end. So I just want to start off with a bit of a description on what is adherence. We know that this definition is sometimes a little bit vague, but the best one that we've found has been the extent to which patient's behavior matches the agreed recommendations from a healthcare provider. For the case of MMS, this is really once a day and hopefully between either 90 or 180 days, depending on the exact protocol being used in a particular location. So we know also that adherence is really important to achieving the desired impacts on pregnancy outcomes that MMS can provide. And we know in the clinical trials, when maternal adherence was greater than 95%, there was a greater effect on reducing infant mortality. And so this is really a critical sign that we need high adherence to have these outcomes. And poor adherence is a real barrier to the successful implementation of MMS. So a lot of the information that we have is really derived from IFA trials or calcium trials. And so the real question here is, what kind of information can we infer from these other micronutrient supplements to MMS, just because of the limited amount of information? And in those trials that compared MMS to IFA, we know that there was no significant difference in adherence between the two supplements. And we also know that there was no difference in side effects. So we assume here that any information that was learned about IFA is really transferable to MMS. And the other thing that we know a lot about is the calcium supplementation. Now, these pills or pills containing calcium are often much larger in size. And so we thought this might inhibit adherence, but we've also seen plenty of trials that have really successfully improved adherence, even with these larger calcium pills. So this can still be done successfully. And so many of their lessons learned, we think, also can transfer quite nicely to MMS. So what do we know about adherence rates to micronutrient supplementation? In those 20 or so clinical trials that compared MMS and IFA, we saw that adherence ranged from about 68% to 97%. So this is incredibly good. And it's really likely because the trial coordinators provided a lot of information to the women and also provided reminders to continue taking the supplements throughout the course of the trial. And so this is often quite typical of a well-run trial. However, in the real world, we know that these adherence rates can be quite poor. And there are a number of reviews that have looked at this, and I'm just listing a few of them here. But in 22 low and middle income countries, they saw that 81% of women received IFA tablets, so that's the iron and folic acid, at their antenatal care visit. And 95% of them consumed at least one. However, only 8% took the recommended dose, which in this case was 180 tablets. So this is quite a drop-off between taking one and taking the full dose required. And then in a study of 22 African countries, adherence to iron supplementation during pregnancy averaged over the course of all of those countries about 28.7%. However, there was a massive range between the countries that ranged from 1.7 to 73%. And this is in adherence to more than 90 tablets. And so some of these countries, it sounds like, are doing a good job in explaining the importance of MMS and implementing this to improve adherence, but some could really use some improvement to this. And the final study I'm mentioning here was a large trial done in China to study adherence to many different types of supplementation during pregnancy. And just 2.7% here, in this case, adhered to more than 90 tablets of MMS, although 83% of women cited that they consumed some micronutrient supplement during pregnancy. So there have been a number of studies that have looked at barriers to adherence and also what we can do to improve adherence. And I do want to mention that this is incredibly context specific. And so I'm not going into too many details, but we know from a number of trials that there are some really commonly cited barriers to adherence. And one of these is, of course, forgetfulness. I'm sure we can all relate to that if you've ever needed to take a supplement or medication. It's incredibly easy to forget to take it. Some cited a lack of information. The women didn't feel like they understood what the supplement was for. Others cited a fear of side effects or harm from the supplement. So again, still like a lack of education and understanding. And then another study looked at the ability to pay and saw a huge drop off if women were required to purchase MMS separately from their antenatal care visit. And so there have been a number of trials that have looked at ways to improve this, and they have all found that these methods here can be successful. So if forgetfulness is an issue, there are reminders, text messages might be appropriate in the context, or developing a buddy system to have someone help remind you, whether that's a family member or a friend who can help remind the women to take the supplement. Increasing antenatal care visits is really well correlated with improved supplementation as well. So this just is a better transfer of information, as well as education about MMS. There are a lot of ways that we can reduce the side effects, for example, taking it with a meal or before bedtime that might reduce that, and educating women about how this can help their pregnancy and improve birth outcomes. There's also some literature that cites providing free supplements can also help reduce some of the barriers to adherence. And this is also a bit context specific as well. We know in some cases, if there is the ability to pay, this can actually incentivize women to take it because they have paid for it. But in other contexts, this is not really appropriate because there really isn't the ability to pay for the supplement. And so having it available free can really reduce the barriers for many women. There are other examples that we've seen, such as the being seen taking a pill can be observed as being ill or associated with being ill. And so if this is the case in a particular setting, which I believe was seen in an Ethiopian trial, it's really important to engage the community in understanding the importance of supplementation and creating that behavior change environment that can really support women to improve adherence. And so this kind of gives a nice plug, I think, for the next speaker who will talk next week on implementation research, because this is a really critical component to understanding the environment and finding ways that we can improve adherence. So I'll just give a brief summary to round out the formal presentation. But we know that good adherence is really important to achieving the desired effects of MMS. And in real world settings, adherence can be really low if women are not well supported. And it's important to assess the barriers and devise ways to limit them and promote good adherence. And we know from numerous trials that we really can achieve better adherence just through some pretty simple interventions, such as educating women, making sure that healthcare workers are talking to the women about the importance and so forth. So I will stop there, and I have just a few. There's a number of really good papers out there, but Philomena helped me pull together these. Of course, the first one I highly recommend with some bias, but this is our systematic review. But there are several others that have looked at iron and folic acid and iron specifically that are very helpful in understanding some of the barriers. And then there's a number of country-specific articles that are not included here, but many people have looked into that as well. So I will stop there.
Thank you, Megan. And as we know, I mean, for all the participants, this is a really short introduction, so you may have plenty of questions. Don't be shy. The references that Megan has put up here are just also copied and pasted in the chat box, so that it's easier for you to copy them or even to click on the hyperlink so that you can straight away go to the place where you can download them. Now, I haven't seen any questions yet, so I will kind of take that advantage to ask you a question, Megan. And I actually don't know if this is true or not, but we all know that the side effects from iron and folic acid, the belief is that that would impair adherence, right? So are those side effects less for MMS? Would we expect, simply because of that it's easier for women to take MMS, or don't we have any evidence on that specifically?
So the evidence that we have in terms of side effects is that they're pretty similar to iron and folic acid. The iron is probably the component of the MMS supplement that causes the most trouble through GI or stomach related issues. And we've seen in the trials that these are fairly similar between MMS and IFA. There's really no differentiation between side effects, whether it's nausea or an upset stomach or such like that. That was the largest complaint. So we really don't think that there will be a difference in adherence based on side effects. But I did see one really good question very early in the chat that mentioned elaborating the ideal method to measure adherence accurately. Is it okay if I address that one? I think that's a
absolutely. Oh, I've overlooked that. Thank you, Elise, that I can, right.
Okay. So I'll go to that one. This is a really great question, and I don't have the answer to this because the trials actually did this in a number of different ways, and it's made it actually very difficult for us to assess. So some trials did pill counting, so they would just count the number of tablets remaining over a period of time. Others were a bit more sophisticated and actually counted the number of times the bottle was opened. But then other trials really just relied on women to report how much they had adhered to, which of course you can imagine there might be some incentive for the women to say or report that they have taken more supplements than necessary in order to kind of appease or show that they were willing participants in the trial. So there's definitely some bias in the self-report measures, but there are some objective measures that can be used to help with measuring adherence, but there's really no gold standard, and that makes it quite challenging to discuss as well. So I wish I had a better answer.
Yeah, actually, I think this is indeed a great question, and maybe we should think about, the more elaborate ways of measuring it. In the past, I've worked with people that were looking at hand washing with soap, and how do you measure, that with some of the counseling that behavior is improving, yes or no? Well, they actually simply hid a chip in a bar of soap. And then could measure actually through the movements, I believe, even whether, the duration or whether it was hand washing or body washing or anything. So, I can imagine that opening the bottle and having a chip, at least in studies, would be a possible way of measuring that. I see some... I'm sorry, I am seeing some questions. So, okay, so yeah, Saida actually repeated that question, so we have answered that. Hema Divakar says, even if we make sure that adherence is correct, the lack of impact in terms of improvement in hemoglobin is also because of absorption hindered due to chronic intestinal infections, phytates, etc. So that is, of course, the same for MMS or for IFA. So that's not even in the adherence, but maybe in the effectiveness of the supplementation. Is that something to take on board in nutrition counseling, Megan?
Yeah, absolutely. And also in the monitoring of anemia and the determinants of anemia, that's also another important thing to consider. When women come into the ANC visits, just really understanding what the causes of anemia are, because if it is due to an infection, that needs to be treated. And adding iron, if it's not iron deficiency anemia, may not be a very useful path forward. And so it's really important to understand what are the other causes. Although we have seen in other trials that in some cases, women start pregnancy so deficient that even with the MMS, which is about 1 RDA for each of the micronutrients, is really not enough to get them completely replete in all of their micronutrient status. So this is definitely something where if you can improve adherence, perhaps you can also nudge these women up in terms of their micronutrient status and improving their iron levels.
Right. Yeah, I think so. So if we're talking about adherence, I see a couple of questions, but I'm jumping to the last one that came in because I find that interesting. Given the low adherence, do we know, excuse me, do we know what this means for the actual coverage rates? So I think that comes to, the definition of coverage. What is coverage? Is that one time, any time, or how do we measure effective coverage?
Yeah, so coverage to me is an entirely different issue as well, because you can also think of coverage as how many women are reached through the platform that's delivering the supplement. So if this is through an antenatal care platform, are you actually reaching all of the women through that platform? Are the healthcare workers informed? Does the supply make it to the healthcare center? So there's a whole number of issues that can really impact coverage. And of course, adherence is one component of that. If you're reaching the women and giving them the supplements and then they're not consuming them, this can really also impact your coverage. But I think really looking at the implementation of the MMS program can help you improve some of the coverage. And there's some really exciting research on that I hope Kristen will talk about next week, to really make sure that everything from the policies and the supply chain and the education of the healthcare workers, all the way down to the counseling of women and the social behavior change that's needed, is really there to make sure that this is an impactful intervention.
Yeah, I agree. And I do believe that our definitions, definition of coverage or the definition of adherence, or going one step further, what is effective coverage that brings all that together? When we're reporting on studies, we need to really make that difference. And I do believe that Philomena has put in a comment that comes out of, I think, mentioned in your publication, that you recommend to specify the recommended dosage and report in the number of supplements consumed divided by the expected number. So it's not, I would say, so probably, does she mean here not the absolute number, but the proportional number?
Right.
Yeah.
Just because this varied also over the trials and what was expected of the women. And so one of the issues that we had was that it was so difficult to compare the different ways that these were reported. And so I think what Philomena is reminding us is that we need a standardized way to report these so that we can really compare them more directly, because that's been quite a challenge. So.
Do you want to add to that, Philomena? I see you're online, so.
Exactly. No, I think that Megan said it all. This comment indeed came from the publication. It was actually one of the reviewers who asked us, can you come up with a recommendation on how future trials can or should define adherence? And we came up with this recommended definition. So we can all in the future look at adherence in the standardized way, if that makes sense.
Yeah, very important. I really believe. So there's two questions, and I'm going to address both of them, but I'm first going to the one that says, thinking about how can we improve adherence. So would it be helpful if participants visit the supplementation center daily? That would be quite a demand on women, right? Did you in any of your studies see any intervention that required that, taking the pill at a site?
At a particular site every day? No, I don't think we saw anything that was like that. But maybe this might refer to like community health days or something like that, where there's maybe a health worker on site available to distribute the supplements. And this could be an effective way as long as it's easy enough for the women to meet this person or attend those sessions.
Mm-hmm. Yeah, I do think, I mean, this is not necessarily the session to talk about, everything that can be done to improve adherence, but I have worked a little bit on social and behavior change in the past. And what you in general see, whatever the behavior is, that it really needs to be a set of intervention. So it's about the counseling and the quality of the counseling, but it's also about the reminders, and it's also about the support system and the encouragement. And then, as you mentioned, it has to be really context specific. So we need to test what works best in a certain setting. I'm going to the question of Hema Divakar now. She's saying, and what instead of a pill, what if we're talking about a kind of MMS fortification? So fortification with multiple micronutrients in that, in our foods, would that be a good way forward? So it's in the food, we don't have to remind the women to take it.
Yeah, I think that's one of the big reasons that fortification is so strongly advocated for, is because it requires so little behavior change. We don't really have to think about it if it's already in our flour or our rice or whatever it is that we're naturally consuming every day. And so that's a huge advantage of fortification over supplementation, in that adherence is kind of automatic if it's done well. And the only issue would be really getting the number of micronutrients into the diet through fortification. Some micronutrients are not easy to hide in foods in the levels that you need them. And they're definitely working on it. There's some multiple micronutrient fortified rice trials being done in India right now that have the really exciting potential to microencapsulate some of the micronutrients that are really hard to distribute and hide within the food. So perhaps this is a good way forward. The other thing to consider is that the micronutrient requirements during pregnancy are quite high. And so when you set up a fortification program, you're really trying to make sure that nobody is exceeding their limits. But for pregnant women, you might actually need them to consume much more of the food to get those levels of micronutrients that we would get in a supplementation program. And so this is another reason to advocate for supplementation, even though there are these added challenges of adherence and coverage.
Yeah, I really think the large-scale food fortification that we're looking at is population-based. So it would never be you would never really be able to meet the additional requirements of pregnant women. I do think there's also been efforts to think about, well, what type of, I don't know if we should call it snacks because that has a negative connotation, but specific foods for pregnant women with a higher level of fortification could be used. But then you run into the behavior that, it's not always in all settings accepted or normal or possible for women to have something, a special food for herself, which, is not available for the rest of the household, or that she may not share with her children, because that, again, is difficult.
Yes. Also, you'd run into the same issues of remembering to take the supplement or to take the food, the specialized food. So that's also another issue there.
Yeah, and then as somebody mentions, of course, and also concerns may rise for that part of the population that's not deficient. I do see another question. One moment. Is there any study showing the adherence to IFA or MMS or any supplementation in relation to the information-seeking behavior? So the way I understand it, if there is in a population more information-seeking behavior, do we then also see that increases adherence?
Yeah, I can't think of anything in particular that suggests that, but intuitively that makes a lot of sense. So if you say had a national campaign to really support and promote supplementation for pregnant women, this might really promote information-seeking behavior among the women. So they may actually be incentivized to go to their antenatal care provider and ask about this and get more information. And maybe then they would really be sort of incentivized through that kind of social pressure to be able to take this and benefit from it. So that might be a really good way forward. And we have seen some studies that have done that, where they promote this as kind of the thing to do for pregnant women. And if you can really integrate it into that social structure, I think it makes it that much easier to improve the adherence there.
I fully agree. I think, I think mothers-in-law, fathers, husbands, all really important to encourage this. One of the things that we're currently looking at, I call them the women voices, but what are women themselves saying? And you do hear that they know what they have to do. So it's not just the information, but they can't, because they can't afford the nutritious foods that are always, almost in any setting, more expensive than the less nutritious foods, the snack foods, etc. So there's a number of barriers that you still have to overcome. I have a last question for you, because then we're almost at time. Question by Philip James of the Emergency Nutrition Network, who's asking, in your research, so the study that you and Philomena published, are there people outside of the nutrition supplementation field that have had real success in increasing medication adherence? So it's not so much your study, maybe more, in the reviews, that you come across successes that have not to do with the supplementation, but other products.
Sure. So that was actually a real question for us with the systematic review, is where do we draw the line and what do we consider? So we did restrict it to supplements just because there is a massive literature on medical or medication and adherence to medication. As you can imagine, someone who is on medication for diabetes or high blood pressure, things like this, it can be really critical to make sure that they're also adhering to the dosage. Most of these studies, or many of the ones that I recall, were done in higher income settings. So they relied pretty heavily on technology to help with reminders and more hands-on, I think, involvement of the healthcare providers. So there is a good literature on that, but I think it's less well developed in low and middle income countries, unfortunately. But I do agree, it's good to think outside the box, because sometimes we do stick within nutrition, and there is some good literature out there on sticking to medication regimes. So yeah, I agree. And then there's one comment about a nutritionist guidance, which is something we definitely support. Women should be advised on, nutrition as a whole, not just the supplementation, but achieving a good diet when possible.
Yeah, and both the last comments for me really go back to what is the type of social behavior change approaches or strategies that we implement. And I love the out of the box idea, because I have in a previous life worked with private sector, learning from them and how they applied their methods to public health issues like the hand washing behavior with soap. I believe that we can learn from that. We have to think a little bit further. And there's a lot of literature now on behavioral economics, on nudging techniques that we could think about to drive adherence. We are at time now, so I think this was really excellent engagements. Thank you for everybody that has joined us. If you would like to know more about MMS, then please go to the Knowledge Hub of the HMHB Consortium website or write us. And we have a next chat on the 10th of November, next week, starting at 10 a.m. Eastern time, 4 p.m. in Europe and 8:30 p.m. in India. And that will be with Dr. Kristen Hurley from Johns Hopkins University and the Vitamin Angels Alliance. And Kristen will talk to us about implementation research in the context of introducing MMS. So very much looking forward to that. But for today, Megan, thank you so much in sharing this with us, and all the participants, thank you for your questions, and we're happy to see you next week maybe. And for everybody in India, I wish you a happy Diwali.
Thank you.
Bye.